I am presenting here paper on comparing different doses of Ondansetron on attenuating spinal induced hypotension in patient posted for LSCS. Spinal anesthesia is the most common anesthesia technique worldwide in cesarean section. It is associated with the hypotension, bradycardia, shivering, nausea, vomiting. Maternal hypotension is the most frequent complication following spinal anesthesia, and it can affect on fetus like decreased uterine placental blood flow, impaired fetal oxygenation, and fetal acidosis. Spinal induced sympathetic blockade leads to vasodilation and leads to hypotension. Parasympathetic overactivity, activation of vasovagal reflex, and increased baroreceptor activity may lead to hypotension and bradycardia. BGR is mediated by stimulation of chemoreceptor and mechanoreceptor. Mechanoreceptor are located in all cardiac chambers, sensitive to decrease in cardiac output. Chemoreceptor are serotonin sensitive. Serotonin is a hereditary trigger for BGR in hypovolemic patients. Study proven that 5-HT3 antagonists prevent serotonin receptor, serotonin induced BGR. Ondansetron is a 5-HT3 antagonist used as an antiemetic. It inhibits BGR and has found to be effective for the prevention of spinal induced hypotension and bradycardia. So we decided to do study on different doses of Ondansetron and reducing SIH and bradycardia in cesarean section. Our aim was to evaluate the effect of 3 different doses of Ondansetron as a prophylactic to prevent hypotension during spinal anesthesia for CS. Objectives are changes in intraoperative hemodynamic parameters, requirement of vasopressor, fetal upper score, incidence of postoperative nausea and vomiting, bradycardia and hypotension. We did a prospective randomized double-blind study was conducted after IEC approval. We total did 120 participants undergoing elective LSCS under spinal anesthesia. Our inclusion criteria were age between 20 to 40 years, AS grade 1 and 2, gestational with 36 to 38 weeks. Exclusion criteria was patient with systemic comorbidity, morbid, obese and short stature, allergic to Ondansetron, local anesthetic drug, severe PAH, QT prolongation, given antiemetic in previous 24 hours, refusal for spinal anesthesia, spinal block. All patients were randomly divided in 4 groups using computer generated randomized study. Patient received 20 minutes before the spinal anesthesia, group NS with normal saline, group O4 Ondansetron 4 mg, group O6 Ondansetron 6 mg, group 8 Ondansetron 8 mg. Pre-anesthesia checkup done. All the routine and specific investigation were documented, written in informed consent was taken. Patient kept NBM, standard monitors like ECG, NIBP pulse ox were applied. Patient's baseline parameters were recorded. Spinal anesthesia was given in sitting position at L3, L4, L4, L5.5 BPVAC, hyperbaric BPVAC and 2 cc was administered after confirming the cerebral spinal fluid through 25 gauge Quincke needle. Till the baby delivered, oxygen was given. The highest level of sensory block was assessed by pre-pit method. The total height we achieved at T4 level for the study. Parameters observed: heart rate, BP, SpO2 immediate after the spinal anesthesia every 2 minutes till the 10 minutes and then every 10 minutes till the end of surgery. Induction to the delivery time noted. Upgar score at 1 minute and 5 minutes were noted. Post-operative vital, nausea, vomiting side effect were noted. Hypotension if occurred, we treated with the ephedrine 6 mg IV. Bradycardia, we treated with the atropine 0.6 mg IV. These are our demographic data which are not significant in our study. The chart is showing that the minimal changes found in mean heart rate and mean diastolic blood pressure in all the groups, which are not significant in significant value. This chart showing that the group 6 and group 8 had a significant value in mean systolic blood pressure and mean arterial blood pressure from 2 minutes to 40 minutes. We can see here the hypotension incidence is more in the group NS compared to group 4, group 6 and group 8, and more dose required in group NS compared to other, and less ephedrine is required in group O8. Bradycardia incidence is more in the group NS compared to the group 4, group 6 and group 8. These are the studies which are compared with the normal saline and different doses of ondansetron, and we can see here the Sahuti and all has concluded that the decrease in mean arterial pressure back to lower in group 4 than compared with the group NS in from the 14 minutes to 35 minutes, which is similar to our study. Also, at all compared 8 milligram with the normal saline, he found that the fall of systolic blood pressure and mean blood pressure from the ondansetron is attenuated but does not influence the diastolic and heart rate, which is similar to our study. And the Turkal is against our study. He found that the ondansetron pre-medication does not attenuate hemodynamic changes after subarachnoid space. Subarachnoid anesthesia does not reduce the amount of vasopressor used and pruritus and nausea vomiting, which is against our study. We concluded that the 6 mg and 8 mg dose of ondansetron is optimal dose of prevention of maternal hypotension with the better hemodynamic stability without any adverse effect on the fetal outcome. These are our references. Thank you.
Okay, thank you for that study. How do you calculate the sample size?
Sir, we calculated from the previous study, Sauer et al. We take the main reference from the Sauer et al. We use the formula and then we calculated with the SPSS version 19.
To the best of my knowledge, SPSS doesn't calculate sample size, but we'll just leave it at that. So, just one question. You talked that the rationale for ondansetron preventing hypotension is attenuation of the basal gyrus reflex, right? But ondansetron, right? Does it have any other effect on noradrenaline reuptake or anything like that? What is the total height of the block?
T4, sir. T4 level.
No, was it T4 in all patients or some patients had?
We included the T4 level only. Above the T4 and the lesser than T4 we excluded, sir.
Oh, you excluded it. What is the full form of SPSS?
Statistical package of social science.
At least you know that. That's okay. So power of the study is very, very important when you are doing such study. 4 groups.
Yes, sir.
You have to have a primary objective endpoints. When you do the power, taking all the alpha errors, beta errors, you have to include that with the confidence intervals. The 4 groups comparison are very difficult to deduce the results and conclusion. You should have taken that part into this thing, and I think going to publication of this study, you have to have the statistical clarity on your study. Then, any other side effects of ondansetron?
Sir, it may affect like nausea, the dizziness, and then QT prolongation.
I'm asking about the cardiac effects.
QT prolongation.
So, did you measure the ECG perioperatively as well as the pre and post operatively?
Yes, sir.
But not, the result it is not there.
Yes.
Because this is the most important, and the pregnant patients, maybe whatever it is, the physiological changes are there. And they may be from 20 years to 35, 36 years. But the people who have been giving the ondansetron, they have found the cardiac effects are more with the 6 to 8 milligram dose. Is a 4 milligram and 6 and 8 milligram, you have to divide according to the body weight. Just can't go with a 4, 6, 8, it's just an assumption. You have to divide the dose according to the weight whenever you are giving to the patient. 4 is the minimal dose where you can have a positive anti-emetic effects. So you have already used it for the hypertensive, prevention of the hypertension. But I think the dose for the anti-emesis, this one, as well as the hypertension is altogether a different dose.
Yes.
So you have to always put a body weight. What is the dose of ondansetron that you use in other
patients to prevent nausea and vomiting?
For 0.8 per kg.
Sorry?
For the nausea and vomiting is a 0.8 mg per kg. For this study we use 0.15 mg per kg.
So it's a 60 kg patient is using 0.8 milligram per kg. That will come to about
5 milligrams.
So yet where I put the body weight is very important. 0.8 per kg is saying.
Okay, no, that's quite a big dose. No, see, I don't know, we usually give 8 milligram of ondansetron for most patients for nausea and vomiting.
Fine, fine. It's okay.